Hello, I am jumping on to do the live that Sarah and I promised for tonight. So we'll just wait for Sarah. And she'll just request to jump on in. Oh, here we go. Tech is like not my thing, so I'm sorry in advance. But I think this is gonna work.
Hey,
Yay! Hiya!
how's it going?
I was like, oh God, this isn't gonna work, but we good.
Cool.
what
Oh,
what's
I'm so
going
excited
on?
for this. I feel like I had so many requests, and then we've just been, you know, researching all day and gone down that
Yes.
mind map route. So, yeah,
I feel
hopefully.
like we're better organized this time though.
Yeah, yeah. We have a lot to cover as well because it is such a huge topic. So hopefully we manage to sort of like fit it in with the hour that this allows us. So we're thinking of maybe if you had any questions that we would open up a Q&A after we close this one because I'm sure that we'll go over quite a lot that you might have questions about anyway. So if you still have some questions after this, we'll jump on again and do a separate video where yeah, you ask your questions and we can hopefully answer them for you.
Cool. And just disclosure, that's my collagen drink that I'm drinking, FYI. It's not like a big thing of
Not a
Guinness
class.
or something. And a massive glass of wine bigger than my head.
Cool.
Um,
Okay.
yeah. So yeah, what are we talking about today?
Tonight we are talking about induction of labor, which I think is yeah, something that like impacts the vast majority of women now because it's something that is becoming pretty much the norm actually.
Yeah.
And we're gonna unpack that and yeah, tell you all the risks and the benefits and the options and things like that.
Yeah, definitely. Um, so yeah, I guess we'll kick off with just talking about what full term is classified as in your pregnancy. So full term is between 37 and 42 weeks. And that's like quite a sort of like general big window, isn't it, Sarah? Like because it can vary vastly from woman to woman.
Yeah.
Yeah,
Actually,
and oh,
yeah, go on. You go on.
there's like a little bit of a lag, so sometimes it's like me on Isa internet, I swear. It drives me batty. um, and yes, I think it was like 3 to 5% of babies are born on their due date. And I'm pretty sure I came across today, I didn't write it down, but I think like 40+5 is like the sweet spot where generally like first time mums go into labour. Would you say that rings quite true just from your experience as well within the midwifery work that you do?
I'd actually say much later. I think Sarah Buckley goes
Oh,
her like big report that she's written, and I think it's over 41 weeks that if women
oh,
go into labor by themselves. Oh, wait, here we go. So I wrote something that only a third of women will go into labor prior to their due date. And
interesting.
I just wanted to reiterate in case no, someone didn't know that your due date is 40 weeks. Um,
Yeah.
yeah, and then like, but that's sort of become instead of the due date, that's kind of become the cutoff date that like a lot of like
Yes.
hospitals are sort of like going in with at the moment. Um, yeah,
Yeah, well, I guess like a lot of women are pretty much like offered that the temptation of an induction from like 39 weeks now, which is crazy when we say that post dates isn't classed until 42.
yeah,
Like you're not, yeah, it's, you know what I mean? It's just insane that it's offered so early, in my opinion. Like that's crazy.
yeah.
Um,
It's becoming earlier and earlier, but we'll talk about that a little bit later on.
yeah, as we go through. So there's like individual factors which will determine like how long that you gestate for. So genetics, previous pregnancies. I think genetics is such a fascinating one. So like if your mum went over or your sister went over, you are more likely to gestate longer, which just is normal for you. There's this whole thing that we talk about today. There's so many variations of normal, and it all comes down to like your personal circumstances. Because I mean, statistics can only tell us so much. And it, yeah, really comes down to your individual, like, genetics and risk factors.
Yeah, and I think it's worth adding as well that we've actually been inducing for generations now. So we actually are
Mm,
losing that key bit of knowledge as well. Like I say, with the women I look after, like I'll ask them all, like, when did your mum go into labor with you? Was it
mm.
natural or was it induced? And the vast majority of time it's coming back that they were induced. So we're even losing that generational knowledge as well, which is a shame.
Yeah, well, that even just like sort of fogs the data, doesn't it? For like, how long did your mum gestate? Oh, no, she was induced. It's like, well, we really don't know what would have been like the norm for her, which makes it harder to determine what's the norm for that individual woman as well, doesn't it?
Yeah.
I'm just sorry, I've lost my spot
No,
already.
we quite
Um,
know that there's honestly just so much that we have to go through. So we thought we'd keep it a bit more succinct this time. Um,
oh yeah, and there's where is it? Yeah, so like reasons are like mostly unknown to why women will go like a bit over. It really depends on like your cycle as well. Like there's all these like different things that contribute to this.
yeah,
And a lot of us really aren't like in tune with our cycle. Like we've been on like artificial contraception and all those sort of things, which like can throw like that whole thing out.
yeah, and even the way that a due date is calculated is on a calculation made up by a man in like the 19th century that
Yeah.
goes off a 28-day cycle that actually has no scientific whatsoever. So, we're
Yeah.
starting from there, and it's not even accurate in itself. And then we're making these huge decisions based off a due date, which is a guess date, and actually doesn't really mean that much.
Yeah, I try to say like a due month. Like
Yeah,
I'm, due in June, for instance, rather than being like I'm due on the 12th.
yeah, it
Just
takes stress off. I even, yeah, definitely
mm,
recommend to people, instead of telling people, your family and close friends and stuff, what your due date is, just give them a month, because then they will stop pestering you, or just give it like a month afterwards so then you can be like, oh yeah, I had the baby instead
yeah,
of,
yeah.
have you had your baby yet? Because it's, yeah, really stressful.
There's nothing worse than that.
Yeah.
So Sarah, what actually makes labor begin?
Um, should we go over first, like what the rate of people being induced are? Because it's actually getting,
Yes. Yeah, let's do that first.
just so we sort of have an idea on why it's become so normalized. But ultimately, it's like the figure sits around 33%, which is similar to what our cesarean rate is. But if you're a first time mum, the figures actually increase to about 40%. And it also differs dependent on your care provider as well. So if you're going through a private obstetrician, you're much more likely to be induced. It's like another 20% increase on top of that as well.
Yeah.
But I guess, yeah, the main reason that women are induced is because they go like over 40 weeks. And the rationale given for that is after 40 weeks, there's an increase in stillbirth rate. But that's actually not broken down and spoken to about, which I think it actually deserves a little bit of light, because um, it all depends about language. So a doctor
Yeah.
or even a midwife might state to you, oh, there's your risk of stillbirth doubles from 40
Doubles.
to 42 weeks or something like that. When actually, for a low risk woman who doesn't have any other medical factors, the stillbirth rate is only from 40 to 41 weeks. It's like 1%. After 42 weeks, it's 3%. And then after 43 weeks, oh no, so it's 0.1%,
Yeah.
0.3%, 0.5%. So ultimately, it's still less than 1%. And then obviously your individual risk factors are going to come into play. And so really those statistics might not mean anything for you as an individual, but it's just something to take into account when you don't have any other medical risk factors and you're just low risk. This is most likely the sort of like category you're going to sort of fall into.
And I think what you said just about like the way it's presented and the like language that can be like quite like fear based, like your risk of stillbirth doubles, and it's like, okay, yep, cool. That may be the fact, but the what it doubles to is still, quite a small amount. Like you still got like a 99% chance of not having a stillbirth.
Yeah, yeah, but it's not really presented in that way. And I
No.
feel like if it's not, then you're not making a fully informed decision as well, because you're not actually getting the proper information.
No.
Yeah, but ultimately, yeah, what starts labor? A lot of women sort of think it is their body that sort of just goes into labor, but it's actually the baby who starts off the hormonal cascade that makes you go into labor. So so the baby produces a hormone in its lungs called surfactant, and what surfactant does is it helps. It's like a soapy, slippery substance that helps the lungs expand. So babies who are extremely preterm, they have to work really, really hard to open their lungs with every breath, and they're more likely to sort of collapse because they don't have that slippery substance in between. So when the baby feels like it's produced enough of that substance, okay, I'm ready to breathe on the outside, then it releases surfactant, and surfactant actually, when it gets to a certain level, interacts with immune cells in the tissue of the uterus. So once those cells get that hormonal release, then that's when they will start releasing prostaglandins, and then the process of labor sort of starts happening.
So it's actually a baby that triggers
Yeah.
labor to begin, saying like, hey, I'm ready, let's get this going.
Yeah, and there's so much brain development that goes on in the last few weeks of pregnancy. So, yeah, at 20 weeks, your baby is completely structurally
Formed,
developed.
yeah.
But the brain develops more and more and more and more as the weeks go on. And there's a huge difference in the developmental kind of like abilities of a baby who is born at 36 weeks compared to a baby who is born after 39 weeks as well. They're starting to notice sort of like longer term things where they're looking at school aged kids and noticing this big difference.
And I think the thing is as well, like in those last few weeks, isn't that where they're like really packing on like the fat and to make them like be able to withstand like a long labor, like it's making
Yeah.
them more resilient, isn't it? So
And then
they're better prepared for labor.
for labor and like the time afterwards as well. So they and their suck reflex is more developed, especially after that 37 weeks. So their
Yeah.
breastfeeding is a bit smoother, and they put on a lot of brown fat. So they have the reserves for when it's normal to lose weight after birth, because you have a couple of days where your milk is sort of starting to come in. If your baby has lots of brown fat, they're really well reserved to sort of get through that period until your milk comes in. So you're less likely to need to supplement feed and things like that, because your baby is well resourced to get through that time.
Yeah. Yeah, definitely. And I think that's all like things that aren't like necessarily outlined when you're being offered an induction.
Mm-hmm.
It makes it hard to make that like informed decision too, doesn't it? When you're not really getting like the full picture painted to you.
Yeah, but that's
Uh,
my way.
yeah, that's what we're doing. And that's why it's important to like source that information as well. Like take control, like do the research, seek out help.
Yeah,
Um,
and I'll list all the resources like at the end of this as well that we
yeah,
ones to go to.
yeah, cool. So I guess there are things that can cause labour to not start. So like one thing, obviously, as we said, like the baby signals when it's time for labour to begin, but stress can really inhibit the labour process. Fear, your body can't release oxytocin if it's releasing high levels of cortisol, which is your stress hormone. So, I mean, obviously that's going to impact whether your labour is going to start. And also, like once you're in labour, that can cause your labour to stop as well, which I think a lot of people don't realise. Like things can just stop. Like mammals in the wild, like if they're like feeling like fearful or watched or in danger, like they're not going to go into labour because it's not safe for them to deliver like their babies. They want to be like in a safe, secure, like dark space where they're unobserved. And like that's the same for women. Like I always talk about like the comparison between us and like a mother cat having her kittens, and like she hides and then she comes out and you're like, oh my god, where did all these cats come from? Like, and mammals don't think about how to birth. They just do it like when it's safe and the right time for them. And I think that there's so much that we can really take away from that as humans and women. yeah, it's nature's safety measure for ensuring like the safety of our baby. But there are things that you can do as well. So I really think like your like mental state plays such a huge part in this. And I can attest to my own personal experience. Like while I wasn't overdue with Emmy, my most recent at all, I was like, nah, I'm not having this baby. I want to go over. Like I wanted to go over because I had plans and needed to move house. And I was talking to my midwife and she said, you know, until you like let go of this, you're probably not going to go into labor. I had a really big cry that night after my appointments. I was 39 plus one, so I still had heaps of time. And then the next day I went to the chiro and I just like made the space better and everything. Like she was born that day. So I just let go of that expectation and the fear. Like I had a lot of fear surrounding like adding another baby to my little brood. And, you know, I did have some fears surrounding labor and I voiced them with Sam that night. I voiced them to my Instagram audience. I did a bunch of stories where I was like, oh, what am I going to do? I don't want to go into labor. And then, yeah, like literally the next night I was holding my beautiful newborn baby. And there's so much like, yeah, there's just so much evidence that like your like mindset plays such a big part in when you're going to go into labor as well. Like you really have to like release and let go. And that's just a theme through like your birth as well. Like that's what you wanting to do, isn't it? Like release and let go. Same with parenting, like release and let go. It all starts at that initiation of labor.
Yeah, for sure. And I feel like for so many women, a looming induction date is a huge,
Yes.
like, you know, ball of stress. And it actually puts more stress on you and, you know, prevents you from going into labor even more so if you like have this day that you have to go into labor by, otherwise you're going to be induced. Well, really, ultimately, like women really fear that like something's wrong with their body. Like, why haven't I gone into labor yet? Why have I gone over so long? When really, yeah, it's your body like functioning optimally if you're going with that mammal like analogy.
Yeah, definitely.
Cool. So I sort of mentioned like the most common reason for induction.
Yeah.
So it's stillbirth is really the one that is used to sort of I don't know, coerce and scare women into inductions. Another Danish study also compared two groups as well, which was only done last year, so it was relatively recent, and it found that it looked at a group of women who were 41 plus 3 versus women who were 42 weeks, and they found absolutely no difference in the stillbirth rates there. And like so much is going to come into play with that as well. So I'll talk about the research and how subjective it is a little bit later on, but there's a lot of things that can decrease the stillbirth rate, and one of them is like continuity of midwifery care. Highest things that helps to reduce that anyway. But yeah, obviously your individual risk factors really, really change where you sit in relationship to those statistics as well. So there's really, really conflicting and differing research out there, and your care provider is going to state to you the statistics that suits their agenda. So if your care provider wants you to be induced, they're going to be stating statistics from a study that has higher rates, and those statistics might not necessarily be relevant to your situation. So it's important to sort of like look out what the other research available is and things like that, because there's a lot.
And Sarah, sorry, just to jump in, like, because I think it would be worth like clarifying, why would a care provider be wanting to induce you? Like, what is their agenda with being like, yep, let's do this. Like 39 weeks, let's book your induction if you haven't had your baby by 40. Let's just get this moving. You'll have your baby soon. Like, what is their, what's the go?
It's like a lot of different reasons. And I think one is convenience, one is control, one is, even though there's only a slight increased risk of stillbirth, your care provider might not necessarily want to take that on. They're like, well, if we can reduce that risk, let's reduce it. But really, they're looking at the bigger picture of things, which, we'll talk about, sort of some of what the downsides of induction and the longer term sort of like flow-on effects of that as well.
Sorry, Sarah's comment of, because there's golf on the weekend. Just
Yeah, I was gonna get to that.
sorry, that just got me so
No,
much.
that's right. Actually, I'm gonna go into that now. So,
Yeah.
um, but yeah, the the most common reason is usually because women have gone overdue, and some of the things that are stated around that are if you go overdue, your baby is more likely to be big, but they also sort of state that your placenta is more likely to fail. Like placentas have an expiry date, which is absolutely something that is
Yeah.
not proven and something that we can monitor anyway, the function of the placenta, usually
Yeah.
how the baby is moving. But there are scans and things that look into the blood flow between the placenta and the baby. So, that's an option as well, whether that's presented to you or not. But I
But
sort of
there's
think,
absolutely no evidence, hey, to be like, yep,
no,
your placenta starts to shut down like that. I
no,
read something that Rachel Reed said today, and it was like, this is not true. This is
yeah.
not proven.
Well, I think it's really funny that there's these two conflicting things. It's like, okay, if my placenta's not functioning optimally anymore, how is my baby growing too big? Like
Yes.
they anyway, but there is options to more closely monitor your pregnancy after 40 to 41 weeks, which is actually a lot of like hospital guidelines. After 41 weeks, it is recommended to do like 2 to 3 days like continuous fetal monitoring, which is the heart rate monitoring that they put around your belly. But that is actually totally unsupported by evidence. It's completely subjective of who's looking at it and like determining what it's saying.
Yeah.
They're inaccurate most of the time. It's only reflective of literally the time that you have it on. So your baby could be looking completely fine and well, and then as soon as you take it off, not be, or vice versa.
Yeah.
It actually increases the intervention rate without improving the outcomes. Ultimately, that's what they've found. Another option that might be offered to you is to do an ultrasound. So also there's a lot of, same with ultrasound, it's subjective as well. They look at sort of 4 different things in the ultrasounds when they sort of look at the well-being. It's usually known as like a growth and well-being scan. So they look at your baby's movements while they're doing the ultrasound, which is obviously something that you can be, taking note of and don't need an ultrasound to tell you what your baby's movements are. The breathing exercises, so babies actually sort of practice breathe, so that's something they look for as well. They look through the blood flow through the placenta to the baby, and they also look at the level of fluid around the baby as well. So that one is not accurate towards when your baby's going to be born. The fluid naturally goes down, and it can be replenished by you staying extremely well hydrated, especially having something with a bit of electrolytes in there as well. So I highly recommend, if you're going to any sort of like later term ultrasounds, really hydrate yourself before you go. Coconut water, something with electrolytes, help you like retain a bit more fluid as well. Otherwise that therefore then becomes a reason why you need to be induced, because the fluid around the baby is low, and it can indicate your baby's not doing so well, when really it can indicate that you're dehydrated. And scans, and it's subjective as well. You can have 2 different sonographers do the ultrasound and get completely different.
I was going to say, it comes down to the effectiveness of the sonographer and their skill, really, doesn't it?
Yeah, I think ultrasounds late term, unless there's like, a medical indication, there's something wrong and they need to monitor more closely with your baby, are sort of looking for something to be wrong. They're sort of looking for a reason to induce you. So another one might be because on ultrasound, this is what your baby's size is, and now your baby is looking too big. Especially when the baby's engaged and the head's down in the pelvis, they are hugely inaccurate on determining the size of your baby.
Even just in general, though, like even not even late term, an ultrasound is incredibly inaccurate.
Yeah, the later they go, it's especially, there can be a discrepancy of 500 grams either side of what they've told you. And 500 grams, well, a 1 kilo bracket for a baby is huge.
That is massive.
Also, like an indication for induction usually is that your baby's too big, when actually the evidence against that is not supportive of inducing for that at all. But yeah, it's just really about like tuning into your intuition, and it's like, how is your baby? You're the one who knows your baby the most. You need to be trusting your intuition because it's something that you need during labor and birth and parenting.
Yeah.
And you're relying on external validating sources such as scans and CTG monitoring when actually they're not proven to be, helpful at all or improve outcomes.
And you know your baby's movements, like you know what their general pattern is, and you know, like in your gut, if you're like, oh, like normally I'm feeling like my baby around this time, like you know what I mean? Like it's, what's normal, whereas like a CTG, as we said, or an ultrasound's only just basing on that one instance in that half an hour period sort of thing, whereas you're with your baby constantly.
Yeah, there's another 2019 study. I'm going to assume it's German because I am absolutely going to butcher this last name because I can't even utter it. By Simon Sedgmon.
We'll link it.
Yeah, link it. Because that's a long one, and that's one last name. Anyway, I thought it was like, yeah, a good sort of like calculation of everything, but it said a small absolute increase in risk on its own without any other medical risks or complications during pregnancy does not justify a policy of routinely offering induction of labor without strong evidence of the benefit of that policy. Because ultimately, we don't know the long-term effects of inducing. We kind of just started doing it. It started to get really popular around the 70s, and every single year the statistics have jumped up and jumped up and jumped up of the amount of women that we are inducing without there being any evidence to support its safety.
Yeah.
There's even sort of, I guess we'll go into it in a minute, but there's even some medications that are used to induce that are not cleared, and that's not the intention of that medication. It's sort of like an unlicensed kind of thing, and it even says in the inserts of the package that this is not what it's supposed to be for. But there is good reasons to be induced. So I think that's worth adding as well, because it should be when the health of the mother or the baby is going to be improved after birth, because there is some medically, like pregnancy-induced medical conditions that
Absolutely.
resolved once the baby and the placenta are born. So things like cholestasis, preeclampsia, high blood pressure, like really uncontrolled diabetes, and like infection in the uterus, and like there are a couple of other things as well. But I think there's probably more reasons that are stated that are an indication for induction, which actually are not proven and are not a reason at all. So things like well-controlled gestational diabetes, babies that are big, women who have a higher BMI, for twins, if it's an IVF pregnancy, for women over 35. So that's like one that is stated a lot, that it's thought that women who are older have higher rates of stillbirth. But actually, I think it was the American Medical Association found that stillbirth rates were still less than 1% for women over 40 weeks who were older than 35. And that it actually increases the chance that the women in that category will have a cesarean section. And having had a previous cesarean section, having scarring on the uterus actually increases your stillbirth rate in your subsequent pregnancies after that. So it's something that needs to be taken into account as well. Things like VBAC are not a reason to induce. Even like 3 years ago, like just when I was starting mid, and especially when I was studying, I remembered that like inducing VBACs was not a thing. Like you don't want to increase that woman's chance of a uterine rupture when
with forced contractions.
Yeah, with induction itself being an increased chance of uterine rupture in all women, let alone women who have a scar on their uterus.
I thought it was actually contraindicated to use Syntocin for a VBAC.
Yeah, but the rationale, it's actually at the clinician's discretion if they feel comfortable doing that. And the rationale for inducing VBACs is we want you to birth during the day and we want you to be prepped for surgery in case you need another cesarean. So
they're literally setting them up to fail from the get-go.
Yeah.
And Sarah, sorry, just with when we're talking about gestational diabetes, would it be similar risk factors for someone who's got like type 1, like
I think
outside, you know?
I think that is potentially different.
Okay, yeah.
And more so because this is my hypothesis around this, or something that I might have read, but I haven't looked into it for a while. But I think because you've got, like with gestational diabetes, it doesn't usually come into play until around 24 to 26 weeks. That's really when the placenta is sort of taking over and releasing high amounts of sort of like hormones which contribute towards insulin resistance and things like that. But it might be different for women who have had pre-existing diabetes, because those like fluctuating blood sugar levels could have been an indication during the baby's development stages.
Okay,
so
yeah.
that's different, and that is something that sort of does require a multidisciplinary approach.
Yeah.
But yeah, I still think it's going to come down to your individual control of your diabetes and things like that as well.
And sorry, and I know we said we'd do questions at the end, but just because we're on the topic of GD, like if you're on insulin, that doesn't necessarily mean like, yep, you'll be induced, even if your levels have been like good on insulin. Is that right?
It's usually, if you're medicated, it's because you haven't been able to control your blood sugar levels. So that's usually an indication. But I think that's a little bit unfair, because I think for some women, they get put on medication from the get-go.
Yeah.
Like without a proper discussion, or without having time to implement lifestyle changes first. So that kind of like takes away that option for some women as well. And
I guess it's a real case by case thing too, isn't it?
Yeah.
And Hayley, like I'd really recommend like flicking Sarah a message after this, because she can probably like point you in like more of a direction with some studies on that as well, couldn't you?
Yeah, sorry, I'm not really reading the comments.
Yeah,
right
sorry,
now.
I just saw it pop up. Yeah.
And because I've only got like 25 minutes left, I'm only like a quarter through our stuff. Yeah, but gestational diabetes, the Queensland Health Guidelines actually state that if you've got well-controlled gestational diabetes where your baby hasn't had excessive growth, then you should just be treated as normal.
Yeah.
And then a couple of other ones are if you've had previous tearing, like a 3rd or 4th degree tear, because induction actually increases your chance of tearing.
Yeah.
They kind of want you to birth before your baby gets too big, but it's actually the size of your baby isn't necessarily an indication on whether you're going to tear or not at all. And the other ones are kind of social inductions are not a legitimate reason to induce your baby. If you only have your family in town for a certain week, or if your partner is on rostered work and can't take days off, some people might think that that's a reason to like have your baby born on a certain day. But with the cascade of adverse effects that can come from an induction, you really need to weigh up whether that's a legitimate reason to bring your baby on.
Yeah, like really weigh up those risks, and like as you've said, like the chances of like that cascade of interventions and like the chances of C-section because of an induction, like it's pretty heavy.
I'll go into sort of all the risk factors that can happen for an induction and why you might actually need more care and not recover so well after an induction compared to a spontaneous labor as well. And that kind of changes things postnatally for you anyway.
Definitely.
Yeah. And your care provider going away is not a legitimate reason. It's not, the birth of your baby is not to conveniently fit in with your care provider.
No.
That's why the induction rate is so much higher in private hospitals than it is.
Yeah. Heavy. It's just so much. I feel like we could talk about this for hours, because there's just so much to cover and so much research and so many different sort of factors that you could expand on. But I think it's really important to note as well that like natural, like when it's like this is a natural way to induce, it's like, no, it's still an induction. A stretch and sweep is still like, it's still tampering with the process. All of those things are still going to potentially change the outcomes of your birth because you're probably not ready. And I know you're going to cover all this, like expand on like what I'm saying, but some natural forms of induction are like nipple stimulation, sex, acupuncture, acupressure, drinking raspberry leaf tea, chiropractic, doing squats and exercise, like spicy foods, castor oil, and clary sage. But like some of these come with quite hefty risks
Yeah,
within
yeah.
themselves. And yeah, just because it's not, like a chemical syntocin induction doesn't mean that it's okay to do.
Yeah, I don't think in any situation where you're trying to bring on the like you to go into labor can really be considered natural because you're messing with your natural physiology and
Yeah.
But yeah, those things like are some of the things that sort of people get told that like put you into labor. But ultimately, if you're not ready to go into labor, you're not going to go into labor. If these things work for you, it's probably because you're going to go into labor anyway. But the only sort of like effective-ish one on there is like nipple stimulation and sex, and it's more so because of the hormones that they release. So if your cervix is ripe and ready to go into labor, these things sort of can help. So nipple stimulation releases oxytocin, but oxytocin by itself isn't going to put you into labor. It's what helps your labor progress. The same with like acupressure, it ripens your cervix, it shortens, it softens your cervix, but it doesn't necessarily always put you into labor. Sometimes these things as well can, and this is like sort of how clary sage works as well. Sometimes it can actually cause a really prolonged early labor and ultimately increase your chance of intervention because you've been in this sort of like pre-labor exhausted state for sometimes multiple days before you've actually kicked into labor. So that by the time you're actually in labor, you're exhausted. So these can sort of have counter effects as well. Things like chiro and exercise and squats, it can sort of like help your baby engage and the baby put pressure on your cervix, which then releases the hormones. Things like curry and castor oil kind of act as a laxative. So it's about irritation. Yeah, it irritates, like the bowel's irritated, it irritates the uterus. It can, if your body is ready to, cause contractions as well. But castor oil is definitely not something you should sort of like, consider
Just give it a go. Yeah,
like
no.
consult with absolutely experienced people, and it's actually not really necessarily something to be advised. I've heard some sort of like nasty stories from it as well.
Also not a pleasant experience.
It causes diarrhea in yourself, and it also causes your baby to pass meconium in the womb,
Potentially, yeah.
lead to more complications.
And I guess that's the same with a stretch and sweep. Like it's only going to be effective if you were going to be going into labor. I think it's 12 hours. Is that right? 12 to 24 hours. Like otherwise it's not going to do shit apart from like maybe irritate your uterus, make you have some like, you're like, yes, like I'm having tightenings, and then it fizzles and you're like, like that's what's happened to me with my third. I thought I was in like established labor, and it was literally like I was not even like my cervix was still really far back and quite thick, and and I was like, oh, but I've had all these stretch and sweeps. And all it did was irritate my uterus and made me really upset and uncomfortable.
Ultimately, it's just stimulating the release of prostaglandin. And prostaglandin, what it does, during your pregnancy, your cervix is long and closed and points towards the back of your body. It's sometimes like 2 to 3 centimeters long, and it needs to go through all these stages first before it actually opens up and starts dilating. So it gets a lot softer, it gets shorter, thinner, and moves towards the front. So this is sort of called like the effacement stage.
Effacement, yeah.
Yeah, so that's sort of what prostaglandin does. It kind of does all that kind of work. So you might be really, really crampy, but it might not actually cause you to dilate at all. So you've had these like, hours or days of on and off cramping, but you haven't actually started dilating at all. And it's just because of the prostaglandin that was released from the stimulation.
And that's what's in sperm as well, isn't it, Sarah? Prostaglandin, and that's where like having sex can be quite effective.
Yeah.
And then obviously,
preparation phases of it. Yeah.
Yes, yeah.
And that's why if your body's really, really not ready to go into labor, that's why an induction process can sometimes be a 2-day plus process, because it needs to do all that work first. So I will go into like sort of the process of induction, but what I really like this sort of quote by Rachel Reed, how she talks about that starting an induction process is a commitment that you believe that your baby's in danger and needs to be born. So if it's sort of like a process that's dragging on for 2 days because your body still needs to do that shortening and effacement and all these sorts of things, then if that doesn't work and it doesn't put you into labor, in some very, very rare circumstances, I've seen women be sent home and come back and start again, but not very often. Majority of the time it's classified as a failed induction, and it's for a cesarean section, when really even had a chance to go into labor.
And I'm sorry, just to jump in as well, Sarah, like with when your body's doing all those early things and they're like, oh, it's false labor. It's not false labor. It's your body getting ready to go. Like if you haven't been tampered with and you haven't had stretch and sweep, this is what your body's supposed to be doing. Like it's just like slowly like amping you up, and it's not to think, oh my God, it's taking so long. I've been in false labor for days. It's like, no, your body's just doing this like nice and gently. It's getting your baby into a better position, and it's, you know, it's doing all the things it's supposed to do.
Yeah. I say like when your body by itself, I just say it's like chipping away. It's doing, and that's why when some people are like, oh, I was in labor for 3 or 4 days or whatever, it's like that's a normal part of the process, especially for your first baby, because for your first it sort of does all that shortening and softening and effacing, and then it starts to dilate. But when you've for your subsequent babies, it sort of does it at the same time. That's why labor is quicker. But I'll sort of go through like the methods of induction. So it's sort of stretch and sweep is usually the first one that's offered. It can increase the chance of introducing infection. It can be quite uncomfortable, especially if your cervix is really, really like posterior, pointing towards the back. It can cause spotting and bleeding, or in really rare circumstances, the care provider could accidentally break your bag of waters, and that sort of like commits you to an induction then as well. It's sort of known as like a mechanical like induction, and it's still definitely not more natural at all.
No.
It's usually something that needs to be done a number of times in order for it to actually work. And to be honest, when I am looking after women having their first baby, I usually highly discourage it because I don't think it's worth it at all. And there's some really good blog posts on the evidence around it as well.
And it is a very uncomfortable procedure. Like it's not pleasant. And apart from like the physical discomfort, like it's very invasive. Yeah.
And then each hospital sort of offers a different process of induction. Another sort of like mechanical method is using a Foley's balloon or Foley's catheter, which I think I'm glad that that's becoming more popular, because I feel like it's more effective than sort of just starting with prostaglandins or like synthetic prostaglandins straight away. Actually, the induction process is then shortened, and women have less discomfort, because I'll explain the side effects of prostaglandin in a sec. But yeah, Foley's balloon is ultimately a balloon catheter that they put inside your cervix as well, like quite an uncomfortable procedure, and then they fill the balloons up with water. And what it does is it's sort of trying to push open your cervix. And the same, it's stimulating that prostaglandin release, and you will usually get cramping like instantaneously after that. And another one is Prostin or Cervidil. So that's like the gel or the tape sometimes that they insert behind your cervix. So that what that is doing is the effacement, the shortening, the softening. So you do cramp quite a lot with that one. And it can actually cause overstimulation in some women who have had babies before. So sometimes if you've had really, quick, fast labors in the past, it might not be a good option for you. Some care providers won't use it for women who have had VBACs because of that risk. And it's actually very drying of the vagina. And I feel like if you're doing multiple doses, because a woman still isn't, soft or dilated enough in order to be able to break her waters, so you can't move on to the next step of induction if that's not the case. They sort of like keep just administering it, and that's more the time. If you get sent home, it's going to be in that stage.
Do they normally do that in conjunction with the Foley's catheter, or are they two separate things, or does it just depend on the circumstances?
It's different in different hospitals.
Okay, yeah, cool.
Yeah, but I think it's definitely something worth, the Foley's catheter is definitely something worth asking for.
Yes.
But I have seen them be more effective when they are used in conjunction with each other.
Yeah.
So the purpose of those previous steps is to therefore make the cervix soft and open enough that they're able to break your waters, the bag of water in front of the baby's head. Obviously, that comes with risk in itself. If your baby's not well engaged in the pelvis, it can risk, the cord prolapsing. It can cause your baby to go into a distress. And it doesn't give, like, not having the water around your baby during labor doesn't give your baby that ability to sort of like move through the pelvis,
Yeah.
which is really, really important and can be really helpful, especially if going into labor your baby's not in a great position. They sort of get stuck in a bad position then. And then the one that in some countries, it's not in Australia, thankfully, because it's something that makes me feel really uncomfortable, but they offer a drug called misoprostol. So it's not licensed for induction. It causes thick, fast contractions, high chance of like fetal distress, and like contractions that are kind of just continuous.
Yeah.
And in Australia, it's actually only used for like termination of pregnancy, or if you're bleeding excessively after birth. It's a very, very strong uterotonic, so it clamps down the uterus. So yeah, I was like super shocked when I found out that some countries use that to induce labor, because just the thought of that makes me cringe. But then what the most common sort of one that people sort of think that this is what induction is, they don't really necessarily get told about all the steps beforehand, is putting up like a synthetic oxytocin drip. So it's very easily gets called oxytocin. It's just the same hormone that your body makes, and really it's not. It doesn't do. It causes your uterus to contract. That's all. It doesn't do the same things as what natural oxytocin does, and it is sort of put on a drip and then titrated up to cause your contractions, and that's usually that's the last option. So.
And that can make your contractions quite hard and fast, can't it? Like
Yeah.
quite intense. Yeah.
Yeah, we'll go over like the difference between those contractions and natural contractions a little bit later on. Yeah, anyway, so sort of what are like some of the risks of induction that I think is important to go over, because I feel like that's not something that is really
It's not necessarily outlined. Yeah.
There's the risk that it doesn't work, and that you're sort of like then set up to have a cesarean. Like I spoke about before, like syntocinon, the use of syntocinon is completely not proven safe. We kind of just started doing it. And induced labor increases your chance of things like fetal distress, in like instrumental birth, so forceps or a vacuum, infection because you're having multiple vaginal exams, uterine rupture even if you haven't had a previous cesarean section. Women are usually less satisfied with their births, and higher rates of birth trauma. So it also
and sorry, and then it sort of cascades to like your postpartum period too.
Yeah, I'll go into that too, because I think that's a really
Yeah,
important that needs to be spoken about a lot more often.
absolutely.
It can also increase your chance of having a postpartum hemorrhage, because you've only sort of got so many oxytocin receptors. If you keep flushing in synthetic oxytocin, those receptors get saturated quite easily, which means they're not as responsive after you've had your baby. So you've got a higher chance of bleeding as well. And then that's when they have to sort of like introduce more medications to make that stop.
Yeah.
There's actually an increase of postpartum depression by up to like 32% with the use of synthetic oxytocins, and it's dose dependent as well. So the more you're given, the higher your chance of postpartum depression as well, especially if that's something that you're predisposed to. So when you're induced, it's kind of not just, they do start it off like quite at a low setting, but they just keep increasing it until you get to 4 contractions within a 10-minute period. But because you're saturated your receptors, you're more, it is highly recommended then that you get actively managed third stage, which means another dose at birth, and then for the birth of your placenta. And then afterwards, if you've bled heavily, they put up another bag with a double the dose of what was in like your induction as well. So you are actually quite like getting quite a high dose if that's sort of like the pathway that your birth goes down. So the difference between synthetic oxytocin and natural oxytocin is just want to reply to that. So in some settings, they turn the oxytocin off when it comes to pushing stage. It's not something I've seen in Australia very often. Some studies have shown that if you get women into established labour, that they can turn it off because what it's already started, and then your body's natural oxytocin takes over. But I feel like if that happens, then it's probably because your body was ready to go into labour by itself anyway. Sorry, my cat's like scratching at the door. Interrupting.
Just wants to be a part of it.
I have a cat.
And none of mine have come in tonight. What the heck?
Yeah, so with synthetic oxytocin, for women, it doesn't cross the blood-brain barrier. So oxytocin is like our love hormone. It's what's responsible for bonding. It has a huge role to play in our breastfeeding as well. So if our body's getting all this synthetic oxytocin, our body's not going to produce its own oxytocin. So we kind of don't get that big boost as well, which therefore can flow onto breastfeeding difficulties as well. But I think the really interesting thing, which is definitely becoming more studied now, and if you're interested in this, look up the work of Dr. Sarah Buckley and Dr. Michelle O'Donnell, that they look at the neurological effects on the baby, because the baby's blood-brain barrier is very, very thin. So synthetic oxytocin does cross their blood-brain barrier, which means they are also not producing their own oxytocin, which is just like oxytocin is like we get the biggest burst of it when we're born, right?
Yeah.
And there has been studies that have observed that after birth, those babies don't show the same breastfeeding interest and cues and things as babies compared to who weren't induced. And the babies don't sort of like engage with their mum as much. So when during the pushing stage, the women and baby get this huge like dose of adrenaline, and what it does, it like dilates your pupils and things. So it's pretty much so what they can stare into each other's eyes, and it really starts that bonding process. So if babies aren't following these instincts because they're not getting those that oxytocin,
natural cues,
surely that's going to have like long-term implications on like social skills and things like that.
And you're sort of you're being robbed, not robbing yourself because like, you're not doing this to yourself, but you're being robbed of like this like massive like transformative experience and this like intense like bonding between you and your baby that, like may take like a couple of days to sort of kick into effect rather than that sort of like instantaneous rush that you get. I guess it is just really dependent, isn't it, on like, as you said, like the dosage of the syntocin and the circumstances surrounding the birthing experience. But it is like those moments post-birth where like you're sitting there and you're just like, I just freaking birthed a baby, and they're like laying on your chest and like looking at you, and you'd like feel like you're looking into each other's souls, like it's so like transcending, like you've really been like having that taken away from you. And it's the highest, like after you give birth, it's the highest levels of oxytocin that you'll ever have as a woman in your entire life. That's just what we said in our epidural talk. Like it's massive, like, and it's so important. And like it's knowing, like, as you said, like this cascade and the risks that are associated with these interventions.
Yeah. And I've got to add, even as a birth like worker, as a midwife, like there is a difference in the room. Like I hate to like let some people know this because it's probably going to be really disappointing, but like when you've been in like a natural spontaneous labor and birth, like you are high off that oxytocin is like a pheromone, like it's addictive, right? It's why birth workers love birth work. It's an amazing feeling. And I find with like it's still amazing, the birth, that like every birth is incredible, like no matter how it happens, and it's always a beautiful moment, but that energy is not the same at all.
No. Well, I guess it can't be because it was like it was augmented and it was not the way it was like supposed to unfold, I guess.
Yeah, and that's sort of like a good flow on because I'm gonna go over sort of like a little bit like what does the research actually say, and I have written some augmented rates in there as well. So augmented pretty much means that your labor has started spontaneously, but then due to either you being put on a clock or getting a epidural, or there's a handful of reasons that they've pretty much put up the syntocin on the induction drug anyway. So there's a couple of studies out there, and they're all really conflicting. In 2018, there was a really controversial study done called the ARRIVE study, and it's if you want to read the whole unpacking of it, Evidence-Based Birth have an article on it, so I really highly recommend that, especially if it's one that doctors are really, really quoting. Because I think it was mentioned at a big obstetric conference, and then everyone sort of like took it and ran with it. So it pretty much says that induction of labor prior to 39 weeks or at 39 weeks had lower cesarean section rates than induction of labor after 40 weeks. That is an extremely biased study. It's performed in the US, which is really different to Australia. And it's been debunked for a range of reasons. So I really encourage you to sort of like look into it further if that's something that's sort of being quoted to you. The Cochrane Review, which is like the library that looks at all the available evidence and then sort of writes up a little concise kind of piece of information, says that with induction of labor, it increases your chance of instrumental birth. But interestingly, it said for compared to labours that weren't induced, and these are at term as well, the APGAR scores, which is like a visual assessment of your baby after birth, and were lower, and there was high rates of nursery admissions, and also it said lower rates of cesarean section. But I think there's a lot to unpack with that as well, because well, firstly, they state that all the evidence and all the studies that have been done are actually only of moderate to low level evidence. There's a high levels of bias, and that they lump all the women together. So these studies were looking at high risk and low risk women as one group and not really separating them. But ultimately, they're kind of like ending statement on their review pretty much said that the data on the safety and effectiveness is lacking. So we can't really be basing clinical decisions off something that doesn't have adequate data.
But yet it's still something that's getting quoted.
Yeah. So I find the cesarean section rate really interesting, and anecdotally, it's definitely not something that you would hear from midwives or people who work in the hospital. So then I looked into it further. There's publicly available reports. I'm not sure if they're in every state, but I'm aware of them in Victoria and Queensland. So they're known as like the perinatal data reports. So it pretty much looks at a range of different things and then tells you the percentages of them. In Victoria, it's really great because they strip it back to per hospital as well, and they actually have all the statistics for the hospitals as well. Not that you really have a choice in Victoria which hospital you go to, because you get allocated a hospital dependent on where you live.
Oh, that's interesting.
Yeah, I don't think it's the same in Queensland necessarily. But yeah, they have kind of like zoning areas for hospitals, especially around metropolitan hospitals in the city. But for Victoria, for women having their first baby, the induction rate was about 13.6% in public hospitals and over 20% in private hospitals. For women having their first baby, their cesarean rate, if they went into spontaneous labour, was 16.7%. But of the women who were induced, their cesarean section rate is 30.6%. So that isn't reflective of what the Cochrane review say at all. It's literally about pretty much doubling your chance of having a cesarean if it's your first baby and you've been induced. Yeah. And then for the Queensland statistics, they don't do it the same way as they don't look at per hospital or anything like that, and they're presented differently. But ultimately, it looked at, in the latest ones were 2007. For Victoria, it was 2008. Oh no, sorry, 17, and Victoria it was 2018. But for the 59,000 women who birthed in Queensland in that year, 29% went into labour naturally by themselves, 17.7% were augmented, and 31% were induced. 22% had no labour at all, which means it was a pre-labour caesarean, which I thought was an interesting thing to add because they have 10 years worth of statistics on their report. So in 1997, the induction rate was 18.6%. So it's ultimately nearly doubled as well.
Yeah.
And the